Molecular classification of breast cancer. Understanding the biological basis for personalized treatment. Welcome to today's podcast, where we delve into the transformative world of breast cancer pathology. The molecular classification of breast cancer has truly revolutionized our approach to this disease, moving us from a one-size-fits-all model to a strategy that targets specific biological drivers. Let's begin with the foundations. Modern breast cancer classification centers on three essential biomarkers: the estrogen receptor, the progesterone receptor, and the human epidermal growth factor receptor number 2. Each of these plays a crucial role in both understanding and treating this complex illness. First, let's consider hormone receptor status. Tumors that test positive for the estrogen and/or progesterone receptors are driven by these hormones, making them well-suited for endocrine therapies. These therapies aim to block or modulate the effects of hormones, which remains a cornerstone of treatment for many patients. Next, we have the human epidermal growth factor receptor number 2. When cancer cells display high levels of this protein, typically due to amplification of the corresponding gene, they tend to grow and divide rapidly. Fortunately, targeted therapies have dramatically improved outcomes for these patients, focusing specifically on blocking the effects of this receptor. It is also important to mention the proliferation marker known as Ki67. This protein is present in actively dividing cells, and a high Ki67 index, often defined as greater than 20 to 30%, signals a particularly aggressive and fast-growing cancer. This marker is invaluable for further stratifying the hormone-driven subtypes. With these foundations in place, let's move on to the core molecular subtypes of breast cancer, which have emerged from extensive gene expression profiling. The most widely accepted classification system draws from the work of leading experts, including the St. Gallen International Expert Consensus and the influential studies of Perrow and Sorley. The luminal type A subtype is the most common form, representing approximately 40 to 55% of cases. These cancers are positive for the estrogen or progesterone receptors, negative for human epidermal growth factor receptor number 2, and display low levels of proliferation. Luminal type A tumors tend to be less aggressive, slower growing, and lower grade, offering an excellent prognosis. Endocrine therapy is typically the primary treatment, and chemotherapy can often be avoided. The luminal type B subtype, accounting for roughly 15 to 20% of cases, also expresses hormone receptors but may or may not be positive for human epidermal growth factor receptor number 2. These tumors tend to show higher levels of proliferation and are generally more aggressive than luminal type A. Treatment typically involves a blend of endocrine therapy and chemotherapy, with the addition of targeted therapy if the human epidermal growth factor receptor number 2 is present. Next, we have the human epidermal growth factor receptor number 2 enriched subtype, which constitutes about 10 to 15% of cases. These cancers do not express either hormone receptor but are positive for human epidermal growth factor receptor number 2. Historically, this subtype was associated with a poor prognosis, but the advent of targeted therapies has dramatically improved outcomes. The primary treatment approach involves chemotherapy coupled with anti-receptor therapy. The triple-negative breast cancer subtype represents 15 to 20% of cases. These tumors are negative for both hormone receptors and the human epidermal growth factor receptor number 2. Triple-negative breast cancers are especially aggressive, high-grade, and fast-growing, with the highest risk of recurrence within the first 3 to 5 years. They are more prevalent among younger patients and those with inherited mutations in the BRCA1 gene. Chemotherapy remains the mainstay of treatment, and emerging therapies such as immunotherapy and poly-adenosine diphosphate ribose polymerase inhibitors are offering new hope for select patient populations. There is also a less common subtype known as the normal-like type, making up 5 to 10% of cases. These tumors share molecular features with the luminal type A group but also express genes found in non-cancerous breast tissue. Their behavior is similar to luminal type A, though the prognosis may be slightly worse. Treatment typically follows the same principles as for luminal type A outside of gene expression testing, which may not always be available. Clinicians rely on surrogate definitions using standard laboratory techniques. These definitions help guide treatment when advanced assays are not accessible. For example, luminal type A-like tumors are characterized by high estrogen and progesterone receptor expression, negativity for human epidermal growth factor receptor number 2, and low proliferation. Luminal type B-like tumors may be negative or positive for the receptor but show higher proliferation or lower hormone receptor expression. Human epidermal growth factor receptor number 2 positive non-luminal tumors are negative for both hormone receptors but positive for the receptor in question. Triple negative tumors lack all three markers. Genomic assays add further precision to breast cancer classification, especially within the hormone-positive groups. Tests such as Oncotype DX, MammaPrint, and Prosina assess gene expression to predict the risk of recurrence and guide decisions on whether chemotherapy is necessary alongside endocrine therapy. Triple-negative breast cancer, once seen as a single poor prognosis entity, is now being subdivided into even more refined groups. Basal-like subtypes are involved in DNA damage response pathways and may benefit from poly-adenosine diphosphate ribose polymerase inhibitors. The immunomodulatory subtype features high levels of tumor-infiltrating lymphocytes and responds well to immunotherapy. There are also mesenchymal and luminal androgen receptor subtypes, with the latter potentially responsive to anti-androgen therapies. To summarize this podcast discussion, prognosis generally follows the order: luminal type A, then luminal type B, human epidermal growth factor receptor number 2 enriched with treatment, and finally triple-negative breast cancer. Treatment is tailored accordingly: hormone therapy for luminal subtypes, targeted anti-receptor therapy for receptor-enriched types, and chemotherapy along with newly emerging targeted agents for triple-negative tumors. The site of recurrence also varies. Luminal subtypes tend to recur later and more commonly in bone, while triple-negative and human epidermal growth factor receptor number 2 positive subtypes recur earlier, often in organs such as the brain and liver. In conclusion, the molecular classification of breast cancer has transformed our understanding of the disease, enabling truly personalized and less toxic treatment strategies. As research continues to unravel the complexities of breast cancer biology, the hope for better patient outcomes grows brighter. Thank you for joining us on this episode of the Everything Surgery podcast. Stay tuned for future discussions on the evolving landscape of cancer care.